Before our next question, I just want to remind everybody again, if you have a question to ask Dr. G, please email us at chat@wrgb.com. Dr. G, through your experience, and I've met a number of parents and individuals who have JA, and see how the disease has evolved, over the year. But in your opinion, how do you feel JA has evolved, and what have you seen to be the breakthroughs that have improved the quality of life of a child with JA?
Well, I think the disease itself hasn't changed all that much, but I think we're doing a better job of recognizing it earlier, and we have got some just amazing treatments now. I've been doing this about 30 years, and when I started, we had a bunch of things we did, but I don't think any of us were really convinced that they were doing very much. In the mid-1980s, we started using a medicine called methotrexate, and that was just like the greatest thing since sliced bread. But the newer interventions that we have are what we call biologic agents, and those really started being released in 1999, 2000, and I'm sure everyone has seen ads for Enbrel and Humira and a number of these similar agents, and that has been just an amazing, amazing change. We have a national conference, the Arthritis Foundation for Kids and Families with JA, and when I started going, there was a lot of kids in wheelchairs and crutches and so on, and you just don't see that anymore.
Right.
And in fact, most of the time with the kids, unless they tell you or their parents tell you that they've got juvenile arthritis, you barely know, because these medicines are so effective. They target a very specific chemical that your body is producing when there is too much inflammation, and by blocking that, you're then able to turn off the inflammation and a lot of the joint damage and associated problems that go with it.
And Dr. G, I know with parents watching today, how does their child get diagnosed with juvenile arthritis? What tests are available?
We do a lot of tests, but really it's what's in medical terms called a syndrome, which is that you have a pattern of history and physical signs and laboratory tests that fit together in a picture that we see over and over again. So we are going to be looking to make sure that there is arthritis. The child comes in saying that their knee is hurting, or they have multiple joints that are hurting. So first you have to make sure that the inflammation is in the joint and not around the joint. And obviously we're going to be doing some x-rays and other kinds of imaging studies. A lot of the laboratory tests we do, in fact, are to rule out other conditions. Unlike adults, where there's a test called the rheumatoid factor test, which is positive in about 90% of adults, it's only positive about 10% of children. So the tests themselves don't necessarily give you the diagnosis, but we end up putting together a lot of circumstantial evidence, if you will, and saying, this all fits together in the picture that we have of someone who has juvenile arthritis. And again, I'm a little older, but I've got 4 kids. My youngest is 22, so I'm a little cynical and sarcastic. So some days, we just say, well, I'm a pediatric rheumatologist, and I say so. But most of the time, we'll see a particular pattern that goes along. As I mentioned before, there are different flavors of juvenile arthritis, and one is called systemic onset, and those children will often have fevers and rashes and a lot of other systemic overall signs that go along with their joints. So they may have literally temperatures that go up every day as high as 105 or 106. Rash will come and go. They'll have lymph nodes and liver and spleen enlarged, and just really look very, very sick. And you have to make sure that they don't have an infection or leukemia or some other things like that. One of the other major groups is called oligoarthritis, and that means a few joints. And so it tends to be 4 joints or less, usually the larger joints, so things like knees or ankles or elbows. And it doesn't necessarily follow the same pattern as where you have it on both knees. You'll have like a knee and an ankle, something like that. The other major group is called polyarticular or many joints, and those kids will have 5 or more joints, but that's often more symmetrical, involves things like the wrists and the fingers. So it depends on which joints are involved and so on as to how you make the diagnosis.
We're being joined by Dr. Harry Gewanter, or affectionately known as Dr. G by his patients from Richmond, Virginia. He's being Skyped in to our debut program of You and Arthritis. We're focusing on juvenile arthritis because July is officially known as JA month. And so, Dr. G, as I'm looking at you on your Skype behind you, you have a "Did you know" sign about nearly 300,000 children in the country have been diagnosed with juvenile arthritis, 3,000 of them right here in the Capital District. I think that number would shock a lot of people. Still, with so many people with juvenile arthritis, why aren't more people knowing about the condition of juvenile arthritis, in your opinion?
It's a good question, and I think I sort of look at arthritis in general as sort of the Rodney Dangerfield of diseases. It just doesn't get enough respect. Because a lot of people think, well, you have an ache or a pain and you've got arthritis, and if you look at the ads, you can just take a medicine and go run a marathon. And really, people don't realize how big a deal it is. And most people don't think about it happening in children at all. It's
correct.
Everybody considers it to be an old person disease, and that's not the case. I mean, in fact, there are more children with juvenile arthritis than juvenile diabetes,
right.
Or type 1 anyway. So it really is, I think, just a societal myth that this doesn't happen to children. And part of the other problem is that there's only about 200 or so of us who are pediatric rheumatologists. So many states don't have one at all.
Right.
I know the closest people to you are either in Syracuse or Worcester, Mass. And so people often don't get to see a pediatric rheumatologist to realize that that's what goes on. And we hear story after story about people going from an orthopedist to multiple other doctors before finally getting the right diagnosis.
Which is really a great segue to our next question about a difference between the pediatric rheumatologist and the adult rheumatologist.
Yeah, we were wondering, there are those pediatric rheumatologists out there. When do you feel it's a point when they should transition to, should I just say, an adult rheumatologist?
I think that the first is when the youth says, I'm tired of coming to pediatricians. If they want to do that, that's fine. Most of us look at it somewhere between 18 and 22, but you really have to start preparing for this when you're about 12 to 14. And pediatricians have different styles than adult doctors, and we do tend to take care of a lot more stuff than adult doctors. So part of this is that the person has to learn that they're going to have to stand up for themselves and speak up and start recognizing things and doing some things on their own that the parents have been doing for them. So, at least from my perspective, when you finish high school and somewhere over the next few years we need to get you on to join the rest of the adult world, and this is somewhere around there. But really, the preparation has to start years in advance. You have to start having person see me by themselves without their parents.
Right.
Have them start calling in to make appointments and getting their medicines straight, remember what their medicines are, and learn those kinds of things. So, because it's not something that you just someone touches you with a wand and then all of a sudden grown up. You got to practice this just like everything else.
Again, just a reminder to everybody who's watching us right now on our debut of You and Arthritis. If you have a question, please send it to chat@WRGB.com, and know Dr. G would be happy to answer any questions that you may have. And you talked a little bit right there about the child being prepared, coming in, asking the questions. What about the parent that might be coming in? What would you recommend as they see that pediatric rheumatologist possibly for the first time? What questions they should be asking?
Well, I think most people have got just, it's most of the time they come to see me, they're pretty shell-shocked about
Yeah.
what's going on, and have got all sorts of images in their minds about what the possibilities are. And, I think we all have dreams for our children and that we think are going to happen. And it just can be sort of shattering to images that everybody has. So from my perspective, the first thing is that we have to make sure that we have the right diagnosis and make
Right.
sure that we are going to be on the right set of treatments. The big question parents always have is what's going to be like down the line. And doctors aren't so good at telling the future.
Yeah.
We all know how many times we all have heard, my doctor said I'd never do X, Y, or Z, and look at this. My view on this whole thing in the beginning is just to say, the kids with arthritis are not necessarily like kids with adults. The adults with arthritis, and so therefore, the prognosis is going to be much better. I don't know how much better, but I do know it's going to be much, much better, and every year it's improving. I think the second thing is for us to talk about what's going on, and even though your child may not complain about things hurting all that much, we watch how they're moving and we watch how they change things. For example, I get more information from watching how the child walks down the hallway, climbs on and off the table, and things like that than I do from what people tell me. And those are much more subtler signs. And so we start talking about, see, these things are evidence that your child's compensating for things. And we need to work on that. And just because they are not complaining about things hurting doesn't mean that they don't have stuff going on. And I think the other big question parents always have is, what are you going to do about it anyway? And that's a very important question right now, because we do have some just fantastic interventions that we can use. And part of the discussions, I think, in the first few visits are, as Americans always focus on, what's the safety issues with these medicines?
Right.
I look at this and go, well, anytime you're going to do anything, you're juggling three balls. The first one is, what's the potential good effects of whatever we're going to do? And the second one is, what's the potential not so good effects? And the third one is, what happens if we don't do anything? We always forget that. And quite frankly, we've done the experiment over many years of what happens if you undertreat children with arthritis, and the outcome is really not so good. So we end up really talking about trying to treat kids much more aggressively now than we used to when I started, because what we've learned is that we can turn off this inflammation early on. We can really prevent a lot of damage that is going to affect the child down the road. And those are really the big issues we end up going through in most of the first few visits.